Hello, everyone. Welcome to June's I-CPEN meeting. Today we have very special guests, Miss Ashley Espinoza. She is from DocStation, and I will let her take over. So, Ashley?
Try to get myself unmuted. Hi, everybody. I'm Ashley Means Espinosa. I'm a pharmacist, a third-generation pharmacist, and I work at DocStation, a medical billing company that is in the business of getting pharmacists paid and activating your provider status, getting pharmacy and pharmacists paid, pharmacy team members paid for pharmacy services. I'm here to talk to you about DocStation today, but really, as Lauren and I prepared for what DocStation would say, this is really a IPHA, I-CPEN, CPESN, medical billing services. A lot of the acronyms that you've heard in the name of billing for your services at the pharmacy. So I'm going to be here. Let me share my little. I have a small deck that just tells you what I'm going to say, and shows you a few things about DocStation. If you're interested in learning more, this is enough to just basically have somebody say, you know what, I think I might be interested in either learning more or taking that next step. And so if at the end of this, you're like, yeah, I want to learn more, I'll be directing you to the DocStation website where you can book a demo and talk about those things. I'm going to be talking specifically about Illinois and our hopes and dreams for being in Illinois. Okay, now I will share. Up here. Okay. We're going to go through a mini demo. I'm going to talk to you about the DocStation value because you have a lot of choices in medical billing. And CPESN, I think correctly, has an agnostic approach saying it's your choice. And I'm here to convince you not to use DocStation, but to say, I'm ready to get into medical billing. As a pharmacist myself, this is the joy of my career to advance the profession in our practice. So just raise your hand, do the thing, is one of the takeaways that I hope that you have. And there are some dollars on the line. So this is a value that, one, you're engaged, two, you're on this meeting because during this, Lauren and I are going to say, hey, we're looking for 10 pharmacies to raise their hand, and you don't get the deep discount and some of the funding that we have to offer today. I'll let the official Illinois folks talk about that because it is not my dollars to give, but there are some dollars to give. And so because you're here, you are the ones hearing about it first. Okay, I'm going to switch over to my other tab. And can you see DocStation Empowering Pharmacists as Providers?
Yes.
Okay, let me make this a little bit bigger. Here's the preaching to the choir part. You guys have passed your legislation. I even attended the Getting Credentialed with Medicaid webinar that was hosted by them. This is the part that you already know. We already know that PBMs are doing the squeeze. We already know that there are other clinical services that have much better margins, similar to our physician and mid-level counterparts. And some people are doing it today. A lot of people are doing it today that DocStation is working with in other states in the union. DocStation at its core, we're here to talk about medical billing, but when we talk about DocStation, if you have never heard of DocStation, DocStation at its core is an electronic medical record by pharmacists for pharmacists. It is for pharmacies. We get approached by physician offices that are on paper. They're like, oh, well, I could do that too. And we're like, yeah, but I'm not going to answer any of your tickets. I'm not going to build anything that's for your practice. This is for pharmacy. So that's our commitment. We are independently owned, still by a pharmacist. And so it is our highest priority is our customer's highest priority. And that is one of the DocStation differences. What you're looking at here on the screen is as clinicians, what you'd expect to see for a health record. You've got patients, their demographic information, they have a health record. It is based on their medication profiles. We have tasks to complete. You can talk to your patients, have schedule for your patients, have them schedule claims, so medical billing, and then here's a little left-hand navigation bar. So if you'd like a full demo, we have that available for you on our website. When you're providing your care, while you might have a notes section in Pioneer, and I know that folks who still type in everything, the working smarter, not harder is something that we need to be able to work into our workflows to provide these services. So DocStation affords flexible documentation, and that is smart notes, template notes, typing where you'd like to, or sometimes you don't need to type out a narrative. You just want to ask the patient questions and understand what their answers are. Yes, no, what are your symptoms, these types of things. So this is a COPD pharmacotherapy management standardized workflow for documentation. Some people call them templates, some people call them workflows. That is all the same to me. Now, this is putting a lot of money on a slide in front of you, but what I want to focus on is this initial box right here. These are things that you can do, and I know that a lot of you are already doing in Illinois. You're offering vaccinations. We are seeing that when vaccines, especially Medicare Advantage, are billed to the medical benefit, the improvement in revenue is significant. And so we've had some folks from last flu season and even into as we approach respiratory season, but other immunizations as well, billed to the medical benefit. Adding on your counseling time. So that's more than just, hey, are you allergic to eggs? Shot in the arm. Do you pass out? No, thanks. Bye. It is what other immunizations might you be eligible for today? Addressing vaccine hesitancy, talking about their comorbidity conditions of things that might make them ineligible, and then full counseling on what to expect. Billing for your encounter time for immunizations, and then medication counseling. So with a number of things that your state has afforded you, your first fill counseling on acute meds, but focusing on naloxone provision through your opioid dispensations. And then some of these things might look familiar to you for Medicare aged folks, med reviews, quarterly follow-ups with that. Seems like everybody wants to talk about remote monitoring, and a lot of people are doing that. And we work in a number of states that offer point of care testing. But just this alone is $300,000. And that the assumptions on here are if you have a sort of an average for a large pharmacy of 4,000 patients in your pharmacy dispensing system, and assuming that 25% of people get a flu shot at your place, 10% get one other vaccine, and that you're doing a healthy number of first fills a day. So that's just the assumptions there. I like being able to say in my career that we're using AI. There's a lot of things related to, depending on what dispensing system you use, DocStation has integrations. If you're billing something to the medical benefit today, you may be billing it to somebody's VIN number. DocStation has that too. We have automations. If you are on Pioneer, Liberty, DRX, DocStation can evaluate what you're dispensing and saying, oh, that was an immunization NDC. I bet you counseled on that. Draft something up for you, pull in the demographic information, which completes about 75 or 80% of the fields you would need to complete, and put that in a queue for you or someone else to work, and to have the pharmacist who provided that care put their clinical notes in there to get those out the door. We use AI in a lot of other areas as well. Some really cool things on payer prediction. Like I see this bin in PCN because of their prescription history. This looks like it could be Anthem. Other things like if you've ever tried to read an electronic remittance advice on a medical claim, it is barely understandable to the naked eye. So we have AI read those and provide AI summaries that say, here's what the payer said, here's why something was denied, and what you should do about it. Using that automation, these are real pharmacies that when we first released this, we're billing about $1,000 a month, which when you put that over the year, we were like, this used to be like top performer. And when we turned that on and they took advantage of each of those, filled out each of those drafts, it really did help them work smarter, not harder, and increased their abilities to bill to the medical benefit. After you get a claim out the door, if you talk to a number of the peer medical billing folks in this space, that's kind of where it ends. Hey, we did the thing. That is sometimes just where your journey begins. And to have a partner that can help bring that transparency and autonomy to the access to your claims. What claims have I created? What claims have I submitted? Who's paying? Who's not paying? And if they partially paid, why? Those are the beginning questions that everybody should be asking. And DocStation has a full revenue cycle suite that the onion is very thick. There's just so many layers here. So I will keep going. I've talked a lot about medical billing, but DocStation has a lot of other bells and whistles, all that come with the platform. There's no special add-ons or anything. And this is my slide deck, so I say people love us. And I just want to address the question that people say, like, well, what is it like to get going? What does that feel like? That it's from setting up your account, getting enrolled with the payers, and it's really a kind of a 1, 2, 3 thing. We have folks that take you through both education, training you on DocStation to make you an expert in the software. And then what's after that is really medical billing education. What everybody needs is understanding, all right, what's happening with this claim? And that is the at-the-elbow support that DocStation provides. Speaking of that, a difference between DocStation and some of the other peers in this space is the ability to get with a person live. In your time zone, in being able to have helpful articles and being able to address your tickets that same day. I've heard some rough stories out there on just simple questions, just saying, and then it goes days and days or maybe weeks without being addressed. After that is that your financial reporting. We've got reports and ways to slice and dice data. DocStation is a sophisticated piece of technology also. And then the other thing I want to say about onboarding is how long does that take? For those that migrate from all PBM reimbursement to the medical benefit, I don't mean to insult anyone's intelligence, because that transition is pieces of even understanding the difference between the feedback. PBM, obviously it's instantaneous. Medical billing, about 2 weeks to say even did you get paid or not. And then setting up with a payer can also take between 1 to 3 months, and that's when it goes well. So full transparency, that is a value at DocStation, that getting your account set up, I could set anybody an account up today. And then we help you enroll with payers saying, hey payer, XYZ pharmacy is going to submit medical claims to you. Accept them. Another entirely different set of paperwork is, all right, now you're going to accept them, and then I want you to do something with them. And here's the W-9 or something to get this business paid. And then another set of enrollments is, all right, when you accept and process these, I want you to give me feedback. I want the gold standard for medical billing feedback, and that's the electronic remittance advices, the ERAs. When that goes really well, it's 45 days. And so during that time, that's when we educate you, onboard you, teach you about the platform, et cetera, to help use that time wisely. And then I've got here a number of months of expansion. Today, I just gave a webinar with one of my favorite customers. He loves us and we love him. And what he is saying was, each time I get a denied claim, I go back to my template and say, all right, what needs to change about this template? So every other time I send that claim template out, I'm going to have success with that. That's part of that Q&A. It's never set it and forget it. And this is work. I heard a quote once that's like, I've never said it's easy, but I will always say it's worth it. And so, I think I'm close to the end. This is the, what wanted to bring you to this because I have a couple different, things to show you about pricing. But I'm going to stop there with the mini demo piece and invite a few questions on maybe capabilities, or inviting you all to talk about your foray into medical billing, people you've seen, questions you have, or I could also keep going. Okay, just want to make sure I didn't steamroll anybody here. Let me reshare again.
It looks like Harry has a question.
Oh, Harry, hi. You're working.
I am. I'm Harry from Maryville Pharmacy down by St. Louis. I We currently use medical billing through Change Healthcare's Revenue Performance Advisors, um, with mixed success for our custom and off-the-shelf compression garments that started over last year. I had my sister Catherine be the main person kind of working through that billing, and I feel like the large part of the hassle and the frankly heartbreak of trying to deal with not only pharmacy billing but also medical billing is the different worlds that they exist in, and let alone how pharmacy are so used to immediate results compared to medical billing where it's a chronic check-in with the insurances to say, okay, did you pay my claim today? Okay, what prior authorization do we need right now? Oh, wait, no, we're not in network. Oh, wait, actually, we are in network. You're just billing the wrong tax ID.
Yeah.
Does DocStation assist with that, or is it something that runs parallel to that?
Number one, I empathize with you because dealing with, we deal with hundreds to thousands of claims every week. And we help people work through that where we're part of all right, what the payer say today on this, you're new to DME billing or other types of things. There are some things that, especially when DocStation is new to a state, I don't know if what they feel about this taxonomy versus that taxonomy. And sometimes it is uh, or this tax ID versus that tax ID. Sometimes it is a trial and error to say, we're going to go with what we believe is sort of that standard of practice from success we've seen else otherwise. But you've seen one payer, sometimes you've seen one payer. And so that is the truth of the matter. And you've got experience with that. There are other things that DocStation can help with. One of those things, as you mentioned, is that chronic check-in. And you've got this enormous amount of claims and you're like trying to call on all of them. When you've got the gold standard ERA enrollment set up, when the payer will send to DocStation what's happening with the claim, that's when you have this color-coded visibility on what's paid, what's not paid, and you can filter on, I just want to work on claims that were denied today. I want to work on claims that were partially paid. And then it's not quite as overwhelming of trying to sort through your big list. That is a way that DocStation can help. And you speak truth when you talk about understanding each payer's preferences in order to ensure that your claims, and I mentioned that gentleman from today's webinar, once you learn that behavior preference, they're like, this is how I want these claims to come through. You can tweak the claim templates within DocStation to ensure that they look like that every time. So that you're not having to like go look at your post-it and say, ooh, what modifier does this payer need for that particular thing? So that is a way that DocStation can help in standardizing as best as possible. I hope that answered your question.
It did, and at least I'm attempting to share my experience where now I am no longer billing for compression garments just because of the hassle that it was, even though you had the program set up, even though we have the contracts in place. It was a lot of going back and forth with patients and Catherine, what happened with this claim? Hey, this patient's called at least 4 different times. What's going on with their insurance? And it's on to add that kind of stressor on top of point of care testing, on top of immunizations, annual reviews, and all of that sort of stuff. It, at least my biggest thing has been integration with a PMS in some capacity. And a couple of years ago, I had talked to another colleague of yours at DocStation and IPHA about the potential of somehow reading these e-care plans, or like you had mentioned, reading the dispensing habits of the pharmacy to then interpret, yes, Max. Um, and I've attempted to hear from Max since then and haven't heard anything. So I do appreciate you coming and speaking with us about that. So thank you.
Yeah. Max did have a baby. So he'd been out for quite some time. Oh yeah, Starlin's seconding that there. And oh, there was a point that I had wanted to say, yes, I agree with. And DocStation has continued to mature. And so from way back when you probably first talked to Max, there are new and interesting advancements likely. So
Gotcha.
I'd love to share this with you. I really appreciate you sharing your experience, because these are the things that high tides raise all boats. And the value of this network is the community that we have in order to share our experience. And when more folks start medical billing, to be able to say, this is what United said, this is what Cigna said for this particular geographic region, because of the, what's happened, where the claims are going for you guys, and layering on your provider status legislation and all the things that you could say, right here, we get paid for this. That is the value of networks. And so I'm glad you all are here. And and if you're looking at joining I-CPEN to be part of this, I'm going to be talking about a data piece that is extreme value. We all know that data has extreme value, and I'll share a bit more with that.
If I may add, just as a final note, I do value the importance of I-CPEN and clinically integrated networks. I do also feel that, at least in the medical space, for what we are wanting out of this network, for what we are wanting out of Illinois in particular, with birth control dispensing, HIV, PEP and PrEP, chronic care management, respiratory assistance, whatever it may be, this is the core piece that will truly incentivize the profession. Because unfortunately, having been a pharmacy owner for 5 years now, there's no incentive like money. And I understand how shitty that is to say, and forgive me for it being recorded, but if there isn't an incentive for a business to take on those goals, or at least something that shows beyond just the surface, we're doing a good job, it's not going to be implemented. And so finding those ways, like your company and like with Habit New and all those other connections, it is important, and it also is going to be vital for our survival moving forward.
No margin, no mission, right?
Right.
So after this mini demo, some of the things that I had touched on that I want to retouch on, to say, like, this is not just the value of a medical billing, but DocStation's value is, one, education, being your partner in that, saying, we are BFFs with IPHA, ICPEN, and to be your at the elbow to be part of this, rather than just selling you a tool. This is a partnership. Transparency is huge. It's just so huge, considering where, medical bill, like DME billing, all the stuff back in the day, this is a black box. So what DocStation designed is for you to be able to see, sometimes to a fault, everything. You can like open these tabs and just see all this gobbledygook, because that's what the payer sent. And also then the AI summary of it. But to see it all, it's not just transparency, but it's autonomy. And every claim field here, oops, not that. I'm gonna go back to one of the slides that I shared. In every claim field, you can see it's pretty tiny, but all of these fields, it's what code are we putting in? What dollar amounts? You need to know what your medical billing partner is putting on your claims. What codes, what modifiers, etc. And if you want to, you're like, my time is worth more than $125. I want to put 150. I don't necessarily recommend it, but you can because we give you that autonomy. And transparency and autonomy is really important to me and to us. Next is service. So I had that slide about service, talked about, timing and who you're talking to and how educated they are on the matter. And then last is data. Here's an example. This is, I've been given authority to share this. This is CPSN medical billing data regarding claims timing. And if you look here, guess who's in first place? Guess who shares the most data? It's DocStation by far. We have a big commitment to our CPSN USA and state partners because when you're a CPSN pharmacy, part of what DocStation makes it easy to do is share that. What am I billing? What am I getting paid for? What's getting denied? So that we have wisdom in a state for a payer so that the next person that comes along will stand on the shoulders of the giants, and that's you all. I'm a pharmacist. I like a bargain. I'm not a salesperson, so here's the price. Our retail price is, this is the sticker price. IPHA, I'd already worked with Starlin and Garth having an MOU looking at how can we make this available and, at a slight discount because of maybe bringing a little bit of volume here. But get this, check this out. CPSN, there is no, I don't even know why we still do this. There is no discount like this. One day it's going to change, but there hasn't been reason to because we know that the value that CPSN brings to the table, it's our strongest partnership. It's our deepest discount. If you are a CPSN member, you get DocStation for $149 a month. That's a screaming deal. Now, MBS, I don't know how much y'all have talked about MBS because that's sort of a newer offering for CPSN in general. And with I-CPEN, with some of the newer changes with CPSN in your state, I'm not sure about the full rollout. So sorry, I keep caveating this. You get 3 months free of DocStation because that's we know that a lot of people that were doing MBS in other states were coming from other medical billing TSPs and saying, I got burned. I'm already paying somebody. I'm in a contract, or let me try this out. Show me that this works. We are so sure of our product, our service, etc., that we're like, yeah, it's worth it to us because we know you'll stick around. And you got to have that commitment. So from IPHA to I-CPEN to MBS, these are all those things. They don't stack. The discounts don't stack, but it gets cheaper the deeper you go down. However, as you know, all of these come with their membership prices as well. I think I repeated this slide here. We go down to, okay, more questions. Harry, I'm so glad that you spoke up and sort of had a conversation with me so that I'm not just talking at a screen. But I have my email here. So maybe I'll keep this up on the screen as we maybe chat a little bit more. And there's a lot in the chat. So maybe this is where, is any of this for me?
It just shows that Rupesh is wanting to get this implemented into his pharmacy, in real situations so that he can teach his friends and other people that are interested. And I saw that Dave Falk did like that message, so I'm gonna hold you to that, Dave. And then Starlin's just saying the steps to get started.
Can I invite I don't know if it's you, Lauren, to talk about some grant money that is available? It is .co, Harry. Thank you for calling that out because don't let your fingers auto type that.
That grant is a Starlin and Garth
Yep.
commenting.
So we do have some grant monies that have been set aside to, as for mentioned with Ashley talking about how there was a different rate for IPHA with DocStation. We have been able to set aside, be able to help fund 10 stores through the project with meeting certain requirements. And if you're interested in learning how IPHA can help with some of those costs, we need to set up a meeting between you as the interested pharmacy and Starlin and myself so we can go through that opportunity will work because it has to meet our grant deliverables and your services that you're providing and the educational opportunities that you're willing to help provide staff to help us accomplish. We've got some grant needs that need to be accomplished and we need your help in doing that. And with your help doing that, we can help offset some costs. So if you're interested in doing that, please put your information in the chat and reach out to Starla and I. We can have those further conversations.
There is a question in the chat says, does DocStation keep a percentage of paid claims in addition to the monthly fee?
Yes, they do. Thanks, Kim. Each of the costs, we have no implementation fee and we have no long-term commitments or you have to do it for 2 or 3 years or things like that. The subscription fee, this is what I'm focusing the subscription fee because that's what the grant covers. That is your access to DocStation's platform. We have pharmacogenomic pharmacists, consultant pharmacists that use DocStation just as an EHR and either only bill cash or they just don't bill to the medical benefit. When you choose to bill to the medical benefit, if it is a product like vaccine, anything with an NDC, that's the better way to summarize it. It's a $2 flat fee because we know that the percentage model, especially for vaccine products, it doesn't work out for a pharmacy owner. When it is a non-product claim, when it's a clinical like encounter claim, it is a percentage of paid claims. So, and that is 10% and paid only when paid.
Silence.
Harry, go ahead.
If I may provide an example of something I'm hoping that DocStation would be able to assist with. I have been working with Casey over with UIC Advance on how to build a model for Illinois for the HIV PEP and PrEP service that was allowed by the state legislature. It is something that we all have kind of come across as far as different hurdles relating to credentialing, being able to set up contracts, all that sort of stuff. The other component of it is, by my understanding with the training from Oregon State, is that we have to do some component of point of care testing at the site at request in order for us to determine whether it's a more immediate situation or whether it's something that we can assess as just like a prep situation. And so in that particular category of being able to bill for a point of care testing, how does DocStation fit into that part?
Let me bump in here. Harry, everything that we did to deliver to Medicaid about our point of care testing, Ashley and DocStation helped us with all those codes, FYI.
Yeah, so it's likely there would be the point of care testing itself, right? And the codes are different on whether it was positive or if something's negative. And then I'm thinking of sort of 3 different code sets on the test, the
assessment.
The assessment, yeah. And that may be it actually, but I always think, okay, what's the encounter time? whether that's a low-level E&M code, that's part of this because it's the, covers the
Yeah,
entire.
yeah, you get-
encounter.
You get a low level E&M code on it. That's, when you send us those codes, they came in threes.
Gotcha. Okay, I guessed right. So that's where a lot of times, so what that would look like in workflow is provide your care, be in DocStation or whatever you want to document your clinical activity in, and then you're going to be bringing up a claim template that is HIV, pepper prep, and that's going to have the fields that you need to complete in that medical claim billing template. And it will already be
And that's
populated.
within DocStation?
Yes. And then
Okay.
that, because of that claim template that you brought up of like, oh, this was a PEP encounter, this was a PrEP encounter. What would already be populated is the codes and the associated dollar amounts for that encounter. So you don't got to look that up, or you don't have to, look at a chart on the dollar amounts. Those would be populated because of the template that was built for that type of encounter.
Okay. So there would not be a case similar to how we experience in pharmacy of being able to assume that there is a paid claim before we provide a service.
If you have this is where rather than saying, I'm going to bill for, I talked to the patient for 25 minutes, I'm going to bill for 25 minutes, knowing what your state provider status legislation affords helps give that guidance so that you're in the fairway, or I'm not good at sports analogies.
You're fine. Yeah.
Yeah.
No.
To know that you're in a safe zone. So it's not just a flip of the coin type of thing. It's, well, this is a service that is covered. And we are going to ensure that when the payer gives us feedback on, I want to see a modifier, if the something came back negative, that those things get added, so they get communicated to in the methods that they would like. So the answer is a bit complex of kind of, it depends, in that if you were trying to bill for something that has not been afforded in your statutes, then yeah, that you absolutely have no idea what the payer is going to do. Now, I can tell you right next door in the state of Indiana, there was some first fill counseling, and I probably consider them not quite a provider status friendly state, but we saw first fill counseling codes get paid. That's because commercial payers can do whatever they want, and sometimes they were paying for some of these preventative counseling things, but that was definitely a shot in the dark. For these particular instances, your level of confidence should grow because of I'm going to keep repeating this phrase, your state provider status legislation.
Right.
Payment for pharmacist services. So that is the, maybe not quite the black and white answer of, you're right, you cannot assume immediate payment, but your chances.
It's at least a different perspective compared to what we're familiar with the PMS.
Agreed.
With that in mind, the other hurdle that at least we have come across, and in discussing with members of the LGBTQ group, that's part of the UIC Advance, and also with other patients that I've had in the area, just kind of spitballing that kind of service. Everybody is so familiar with getting these services for free. And a lot of it is related to online platforms like QCare, Mr. There's a couple other online services where effectively they not only bill insurances, but also have access to grants and things like that to be able to pay for those kinds of services. And so a lot of the community who at least are currently exposed to PrEP, and certainly not all of Illinois is going to be that way given the large swath of rural area we have. It's something that I wonder of being able to provide that kind of service, only in the sense that if you're trying to treat everybody that walks in the door and you have that sort of uncertainty for what kind of reimbursement you're going to get on a patient, but you're just not charging anyone to begin with. It's kind of like how I see what we do with Medicare Advantage plans, where we have to give an ABN for a lot of patients, even though we have an approval, just because there's so many other caveats to those different programs. So I think that will change, given that there will be changes to HIV grants. Not hopefully. I do not hope. I do not hope in any capacity, but I'm fairly certain there's going to be some changes to that dynamic in the future. But that's at least something that I think that if pharmacies are able to provide that sort of security that they would have gotten from other resources, then I think that kind of service can explode, let alone everything else beyond that, birth control, chronic blood pressure monitoring, all that sort of stuff.
Those services, in a reaction to that is volume of services like that in your pharmacy. And so I might be putting Rupesh on blast here to say like, hey, Rupesh, if you're available to speak up here. But I thought Rupesh had a really great perspective where he's like, that's great, and I'm going to try to build that. But what about the high volume stuff too? And as one gets into medical billing, I've talked to so many pharmacies where it feels that overwhelming of, this feels so risky because I don't know if I'm going to get paid. The community in which that I might be engaging, somebody who needs oral birth control, somebody who needs HIV prep. I don't know, just walking in the door, if they're eligible or if they're interested, and then the uncertainty of that. And that's where DocStation at one point we're like, wow, you can do anything under the sun. But you know what? If it's so overwhelming that we started saying, let's start with vaccines. So I'm like pivoting 180, talking about HIV prep and saying, what about vaccines? Starting with vaccines, something that you're likely doing, especially in respiratory season, over and over again, saying, make sure that you're doing that 3-legged stool: product, admin, and counseling time to the medical benefit. And then Rupesh brought this up of like, what else can we do? What's high volume? What's something that we can not just build into our workflow, but because we do it so many times, that then the medical billing portion of that is also just regular, and those claims are going out the door. And when you take any extra revenue and know that it's happening in high volume, even if it is just $13 extra, multiply that by a few hundred, and that's really meaningful. So that's my reaction to that. Those thoughts are valid, and those challenges are also here on the table for consideration as one dives into those things. And I want to encourage everybody to consider what to dive into. And when the world is your oyster, the things that I would recommend to start with are vaccines, vaccine counseling, billing vaccines to the medical benefit, vaccine counseling. What else is high volume? We had talked about naloxone, provision with your opioid prescriptions. Okay, I'm going to do this so I can see your faces. And I hope that if you're interested in my email that you've already written it down. But Lauren does have it if you ask for it after the fact. What else?
I have a question. Several people have asked me, when we start working with some of the commercial insurances, or in particular the commercial MCOs that do Medicaid, do they charge us to test claims? Do a claim test before we start sending?
Is Medicaid? Is that the question?
Insurance, the payers of so 75% of our Medicaid is managed Medicaid, and they're with Molina and all the different commercial insurers. And I'm part of this commercial insurance learning collaborative, and some of the commercial insurance charge a fee to test your claims to see if have you ran across that?
I have not.
That's good to know.
And when you heard it that, like, how much were we talking?
So, it went from a small fee to up to $500, depending on
Wow.
the number of claims tested.
No, we have not run into that.
It came out of Pennsylvania. They're starting to, they're starting to push a little harder and getting more contracts with commercial insurance. So they're probably by far ahead of the game. But that was in her summary notes that one of the things we want to check with when we have the commercial insurers come in and talk to the collaborative. In the old days, we used to have to pay claims. You have to do the claim checks. Harry, didn't you experience that with change?
Is that what you're talking about with the per click transaction fee?
Yeah, the not so much with RPA, but rather I was at least kind of referencing the PMS with a switch, that there is technically a fee for every transaction that we do within the pharmacy program as well. So for every rejection that we get or every test claim that we get, there are not only fees from the PBMs, but then there's also fees on the relay switch that we have to pay McKesson for, that sort of stuff. I'm under the impression that my fee that I pay for RPA covers 800 transactions. It's either 5 or 800. I'd have to double check, but effectively, if you do more than that, then they will charge a larger percent or larger amount per transaction that you submit for that month. And so at least everybody wants their literal time.
Now I can say that, like, when you bill through TSP, that's what CPSN calls us, a technology service provider. When you bill through via medical billing, the clearinghouse, like Change, like Availity, is kind of like the switch for medical billing. There is a cost associated with that, but that's something where with DocStation as your TSP, we have connection and we actually have it to both because of the Change apocalypse last year, where we said, "Ooh, we definitely need to make sure that we have redundancies here." I know that costs DocStation money, but again, it's like cents, and that's something that we consider a business cost. So we don't. Yeah, that is something that the subscription fee is part of what pays for that. But I've not heard of hey, I'm United Healthcare commercial, and this is the first time I've seen your transaction. I'm going to charge you to test it. I have not seen that. Just more of like the general, everything costs money. And when DocStation takes pharmacies medical billing claims and processes this as your TSP, that costs us, some money. But also because we have hundreds of pharmacies, we have that economies of scale.
Right. So and then that's basically covered under your 10% that you keep after it's paid.
That's correct. And like if you're a Pioneer user, we have to pay Pioneer for some integration stuff. So there's a lot of things that go into it.
Okay. So yeah, you should probably expand on that. So what the integration costs are.
And we don't pass those along, so those are all just like built in. And those are some things that when people are like, well, what am I really paying for? That's part of what's included in that. But what I usually focus on is the tools and services that you have. So you're getting an electronic medical record so that you don't have to keep fancy Word documents or work with the small fields of notes in your pharmacy dispensing system. This also is the workflows that you have afforded to you in order to provide these types of things and be able to have workflow templates that are like, do this, say this, ask this. And I love teaching people about the templates that we have because it does two things. One, it helps you train your team, whether they're old or new, and you say, use this template. The second thing it does is it standardizes your patient experience, regardless of who they talk to. So they can have a standard experience of when I come in to talk to somebody about XYZ thing, I'm going to have a good experience where some people are thorough and some people aren't. At least there's that minimum of of what's covered because of using one of those workflow templates.
So do you have a library of workflow templates?
We do. Yes. It's kind of like, I remember back when like first time I got an iPhone, I walked into an Apple store and I was like, do you have a list of apps? And like that's so silly now to think of that because it's just such a big thing. It's like, well, what's a whole library? So we have a very large library that is cut up into, is it point of care testing? Is it, GAD assessment? There are all sorts of things. And you can build your own workflows. Like I have a number of people who are doing weight loss clinics and they do motivational interviewing, your first intake, 15-minute free consultations type of thing. And then they take them through a standardized intake form. You can go, the world is your oyster there. You can go whatever route you please. But also things that are literature based. Like we have a Paxlovid assessment, and you can tell by the way that it's worded, it's sort of tertiary information intended for a pharmacist provider to answer these questions on eligibility for Paxlovid. All sorts of flavors there. I'm looking at the questions.
Yeah, I don't know if you saw in the chat. So it looks like we have a few people who are interested in being the first 10. So shout out to Jacob for being one of the first, and then Rupesh also following up. So
wonderful. And if you're on the fence, I hope that that grant funding eligible to you is enough to get you to give it a try. And if you're still on the fence, that's something where we'd love to, book a demo with DocStation to share more. And you can learn one-on-one and get your questions answered in a more intimate setting.
yes. Any other questions for Ashley?
If I may have one more question.
You may, Harry.
So you mentioned Pioneer, and I'm assuming you were talking more so in integration. Is that correct?
Yes.
Are there other platforms that DocStation has integration with, such as Liberty software?
Mm-hmm. So to answer your question, at baseline, every pharmacy management system, dispensing system can bill to DocStation's bin. So if you are sending product need to bill that to the medical benefit, we can you can bill to DocStation's bin. Now we have deep integrations with Pioneer, Liberty, and I can always say that they're newer, but they're not quite as new anymore, DRX. Those are deep integrations, meaning that we can read what the dispensing activity and identify, ooh, that was a NDC for a vaccine. I bet you counsel on that, and draft a claim for you. For others that are not on the deep integration ones, we do CSV uploads. You do CSV uploads into DocStation so that you don't have to build patients, manually add them. That way, those that are in your dispensing system can also be in DocStation with the right amount of data to generate a medical billing claim and not have to spend a bunch of time. So
Okay.
never to fear if you are not a Pioneer, Liberty, or DRX customer.
Okay. I appreciate it, and I appreciate your talk. Thank you very much.
Thanks, Harry. You made this a great conversation, and I appreciate all the other questions in the chat and others, and for your attention, everybody.
Thank you, Ashley. Before I let y'all go and enjoy this Thursday evening, which is still very hot in Springfield, I want to introduce our upcoming new fellow who's going to start next week, which is Dr. Ashley McKetchin. If you want to say hi and introduce yourself real quick, where you graduated from, etc.
Yeah, hi everyone. My name's Ashley McKetchin. I just graduated from St. Louis College of Pharmacy in Missouri, but I am a native of Springfield, Illinois, so very excited to get back and also follow in the footsteps of Lauren and also join the IPHA team. So hopefully I have some big shoes to fill, so hopefully I do good, but excited to work with you all and be with you all.
Yes, we are so happy to have another great fellow. And then Our next meeting will be July 24th. And so you guys will not be getting rid of me for I-CPEN because I still will be on board. I just will not be with IPHA technically. You have Ashley for that, but I will still be your I-CPEN Managing Network Facilitator along with the rest of the team. So with that, mark your calendars for Thursday, July 24th for our next meeting. Have a great evening.
Thank you, Ashley. Happy anniversary. Have a good dinner.
Thank you.
Night, everybody.
Good night.